All right. Everyone hear me okay? Yeah, cool. So today we're going to be talking about non-ST elevation ACS, and I'm trying to really just go through management of this with you guys, kind of the nuances of management, and then we'll kind of get towards long-term management too with like antiplatelets, and we'll also touch on like CABG versus PCI. So it's kind of be what we're going to do for today. So we're going to start off with a question. So what I'm going to do is that, so I'll start here with the question, and then we'll go over to Kahoot, and then you guys can answer the question on Kahoot. All right. Could someone do me a favor and throw that, actually, let me figure out that Kahoot, whatever. All right, so this is the first question. And this is going to be kind of an interactive question as well. So you guys can ask me questions to get more knowledge about this patient, which is going to help you answer the multiple choice question on Kahoot. So 7-year-old male, past medical history of hypertension, hyperlipidemia, diabetes, and smoking, presents to the hospital with chest pain. So he's had chest pain for the past 2 years, but it's been progressive, and for the past 2 weeks, his chest pain is much more severe. He now says it's constant. He has not been able to walk as far as he used to walk. His home medications are metformin, lisinopril, atorvastatin, and aspirin 81. Vitals are heart rate 85, respiratory rate 13, blood pressure of around 160/90, pulse oxygen 98%. The question is, how do you define this patient's chest pain? And I'm going to have you guys ask more questions. Either you can put them here or you can throw them in the chat, just to kind of elucidate more information to answer that question at the bottom. What else do you guys want to know about this presentation? You can either chat or unmute yourself, up to you. All right, where is the chest pain? So just center of his chest, and I'll give you a little bit more quality. It says it is pressure-like. It is worse with exertion. It is, so good question. It is now present at rest, but before it was only worsened with exertion. So over the last day, equals present at rest. He has not tried nitroglycerin. But it does go away when he stops moving. Sometimes, but now it's a little bit worse. It used to go away and stops moving, but now it's kind of stays there. And if you guys want, you can ask for any labs you want, as well as EKGs, or kind of give that to you. All right, so first we'll give you the EKG. I mean, anytime anyone has chest pain ever, get an EKG. It's pretty easy. Does anyone want to, you can put in the chat, you can say it out loud, just say some stuff. We'll get through this EKG together. Anything you see, anything that's concerning, or is this not really too bad? I got all day. Do people think it looks relatively normal? Oh man. I always say there's a there's reading EKGs and there's reading EKGs in a presentation, so they're much different. Thank you, Grant. Appreciate you. Left axis deviation, T wave inversion, and V1. So yeah, so Grant's talking about the left axis deviation. So right here, you can see that the S wave is bigger than the R wave. So that would be left axis deviation in 2. And then he also said T wave inversion in V1. So yeah, little T wave inversion here as well. The only other thing that there is on here is does anyone know what these are called? Yeah, thank you, Mario. Yeah, these are Q waves. So this can be a sign of an acute or a chronic infarct. So he did have a previous EKG in 2017, and he had the same exact Q waves. So not too concerning. So this is something chronic. He never had an MI before, but it looks like he does have Q waves in his inferior leads. And then the last one he has here is just like he has an APC with an aberrant conduction deafness Purkinje system, right kind of at the end of the EKG. So nothing too crazy. We got the EKG. The biggest thing you really want to rule out, because it's a diagnostic imperative, is a STEMI. So no STEMI. And then no ST changes, but some non-specific T wave inversion. All right, anything else we want before we move on to the question? Any other, anything? History, labs, tropes, thank you. So troponin, so negative times 2. So now the question is going to be, how do you define this patient's chest pain, right? STEMI, atypical chest pain, unstable angina, or angina. So let's go to Kahoot. I'll give anyone a couple minutes to sign in. Everyone got Kahoot? All right, we got some peeps. All right, let's start it up. So this first question. Four, three, two. All right. So the correct answer is unstable angina. And we'll see who is on top of the leaderboard. We got AAA on top of the leaderboard now. All right, so unstable angina is the correct answer here. And the first thing I think you have to realize is this angina, and there's kind of a couple different ways to do this. The one that's typically used is the grading system for angina, which is typical angina is 3 out of 3. So what goes into that 3 out of 3, and he had all of this, is basically chest discomfort, with like consistent quality and duration to angina. So his chest discomfort, it's pressure like, you guys didn't ask, but it did radiate to his shoulder. That's another thing that has like a likelihood ratio of about 2. It did, it wasn't sharp. It wasn't pleuritic. Those are things they asked, like, is it sharp? Is it pleuritic? It wasn't reproducible to palpation is another thing that can be helpful. So it kind of hit all of those things in which it sounded like anginal chest pain. The other two that you have to think about, or that's kind of part of this definition, is worse with exertion, or emotions, and improved with rest, nitroglycerin. So he really hit 3 out of 3 for this. So he did have typical angina. So this has about a likely ratio of 6 for being cardiac chest pain. Atypical angina is 2 out of 3. It's not that helpful. You can't rule in cardiac chest pain. You can't also rule it out. And then non-cardiac is basically less than or equal to 1 out of 3. And when you have non-cardiac chest pain, the likelihood ratio is 0.1. That is secondary to a cardiac cause. That's very helpful. So if you really only have 1 of these things or 0 of these things, then you're not really it's going to make it much less likely that this is a cardiac cause of chest pain. So it's angina. We know that it's typical angina. And then kind of what is the definition of unstable angina? And this is really a clinical diagnosis. But unstable angina can be any of the below. So new onset severe angina that really limits someone from being able to walk. Worsening from baseline. This is kind of what he had. He's had it for a while, but it got much, much worse. And then last one is going to be rest pain. And you have to do it greater than 20 minutes. So he was unstable because he has rest pain, and he also has worsening from his baseline. So if you have any of those, it's a clinical diagnosis of unstable angina. All right, next question number 2. Let's just get through these. So we diagnosed him with unstable angina. He came to the hospital, non-reproducible, non-pleuritic, exertional chest pain that's worsening at rest now. EKG with no acute changes, has some old Q waves, and he has a negative troponin. Normal vital signs. The question here is, how do you want to treat this patient? So do you want to do aspirin, ticagrelor, metoprolol, nitro, heparin, Lovenox, atorvastatin? Do you want to do all that except for you don't want to do the metoprolol or the ticagrelor? Do you want to do all of those but without the metoprolol? Or do you want to do basically the same, but your dual antiplatelet is going to be Plavix? All right, so those are the questions, and we're going to go back to Kahoot. All right. So same question. This is question number 2. What do y'all think? I think I should have made these longer. All right, so most of you guys got it. That is the correct answer. We'll see who's on the leaderboard. AA is going down, and Tresto is going up. All right, so let's get back to this case. All right, so correct answer is A. So kind of going through this real quick, and I think this is kind of a cool thing about, unstable angina and NSTEMI, STEMI, is that you're really asking history and doing a physical because you're trying to figure out what is the underlying pathological state which is going on in their coronary arteries. So here's a typical patient here with stable angina, right? They're going to have that history where, they get chest pain at the same amount of exertion every time because they have this plaque that has a cap on it, and it's not thrombosing, it's not getting worse, it's just staying there. And anytime they kind of max out their demand to the heart, they start getting some chest pain, right? That's typical stable angina. Once you get to unstable angina and STEMI, there's a rupture of this plaque. So here's this, lipid-filled plaque of the coronary artery here. And a lot of times, it hasn't undergone a ton of remodeling, it ruptures, and that rupture can either cause, somewhat occlusion of the coronary artery called an NSTEMI, or unstable angina, or complete occlusion called an NSTEMI. So treatment-wise, I always kind of think about it, from pathophysiology and like, how do we treat this? So the first one that you really want to think about is how are we treating this thrombosis here? So when you think about thromboses, it's from two things, right? One, platelet aggregation, and the other one is fibrin polymerization from the coagulation pathway. So treatment-wise, it's going to be dependent on that. So, decreasing the coagulation pathway, you're either going to use heparin or you're going to use Lovenox, right? So everyone should be on that. If you think the patient's going to get a cath in the future, you probably want to, do heparin. If you think the patient, you might do conservative management, and then and then end up doing a stress test to figure out, if you're going to cath them or not. In that time, Lovenox may be better. The second part, is going to be the anticoagulation. The second part is going to be antiplatelet. And the question is, we always do aspirin 325, and then you do 81 daily. But what is the second antiplatelet when you have someone that comes in like this? So anyone who comes in with ACS, the second, as long as they don't have any contraindication, the second one should be ticagrelor. And this is the Plato trial that showed that ticagrelor had better anti-ischemic effects than Plavix. All right, so two, so that's kind of number one here, really infecting that thrombus. Two is going to be plaque stabilization. So you guys got this right, atorvastatin 80. And, this obviously prevents long-term propagation of atherosclerosis, but in the acute setting, it also helps stabilize this, basically stabilize this plaque. So it can help prevent further infarct in like the very near future. So everyone should get atorvastatin up front as soon as possible. Third one that you want to do is decrease your cardiac work. So really you're just, decreasing, there's not enough supply of oxygenated blood to the myocardial tissue. So you're trying to compensate and decrease the myocardial demand. And there's kind of two ways you can do this. One is going to be metoprolol. You usually do 25 milligrams, and it's going to be tartrate, 25 to 50 milligrams Q6 to Q12. And this does really have a benefit. This actually can decrease the infarct size. So this is something that you want to really start early. Contraindications for metoprolol, it's going to be kind of things that you would think about. Anyone in either greater than second degree heart block, anyone that's bradycardic, anyone that has heart failure symptoms, you're really not going to want to do metoprolol, or anyone who's hypertensive. And this patient, is none of this, so this patient can easily get metoprolol. And the other one that you want to do, and this doesn't really have a morbidity or mortality benefit like metoprolol, is nitroglycerin. So usually what you'll do is you'll do kind of 3 tabs, and then once you get after 3 tabs, you'll start the patient on a nitro drip. Obviously, some contraindications to nitroglycerin is you don't really want to do it in patients who have like in the right side infarct, especially if they're hypotensive because they're preload dependent, and anyone who has taken sildenafil. You'll always get that question. So those are the main things that you want to treat, and that's kind of going over that last question for you. All right. This one I think is getting a little bit harder than the previous ones. Let's do it. So he started on that treatment, gets aspirin 325, loading dose ticagrelor, metoprolol 25 milligrams Q6 for a target heart rate of 55 to 70, heparin drip, atorvastatin 80. He does become chest pain free with his first sublingual nitrogen. Doesn't have any ventricular arrhythmias on telemetry. He has completely normal vitals. I'm going to give you guys some time for this one. but what would be the optimal planning for cardiac catheterization based on this patient's TIMI score? And actually, why don't we do the TIMI score real quick? So this might be a little bit easier for you guys. So does anyone know the components of the TIMI score? There's a couple of them. Yeah, age. Thanks, Joey. So age is one. So he gets that, right? So he's age greater than 65. So he gets 1 point for that. Nice. Oh, so let's see. Rahid said aspirin use. So he did use aspirin, took his home aspirin yesterday. Two, aspirin use. So he gets that. He gets a point for aspirin use. Three, there you go, Joey. Greater than or equal to 3 cardiovascular risk factors. So he has those, right? It's another point for that. He has hypertension, hyperlipidemia, diabetes, and smoking. So that's 4. Another one would be a present family history of like early heart disease as well. Doesn't have that, but he has 4, so he has a point for that. Prior atherosclerotic event. Yeah, so I think that one is, and he doesn't have this. This would be known CAD greater than 50%. So greater than 50% stenosis. He doesn't have this. And then the next one. So these are basically based on history. These ones here. These 4, and he has 3. He basically has 3 out of the 4 right now. The other ones are based on presentation, and I think Rahid hit a couple of them. Troponin, so positive troponin. So it doesn't have that. The next one is going to be severe, like greater than 2 episodes of severe chest pain in the last 24 hours. So he does have that. And then the other one is going to be like ST changes. So he didn't really have any of that. He had like a little QA version in V1, but didn't have really any ST changes. So he has a TIMI score of 4. All right, so with that TIMI score of 4, are you guys going to do immediate cardiac cath right now? Are you going to do a cardiac cath within the first 12 hours? Are you going to do it within 72 hours? Or are you going to say, let's do conservative management, we'll do a stress test first, and then we'll risk stratify, see where you got to go? All right, most people got this right, cardiac cath within 72 hours. Perfect. All right, who's up? Entresto still killing it. All right, let's get back to this real quick. So cardiac cath, this is the correct answer. So just going through this, right, we already calculated this. Boom, 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 and this guy right here. So the question is kind of how do you risk stratify these people and how does that really affect your management? So starting off the top, you know, this is a non-ST ACS, right, which includes NSTEMI and also unstable angina. It includes both of them. So, you know, you kind of do treat accordingly. So we did that, right? All these patients should get antiplatelet, they should get anticoagulation, and atorvastatin, things to decrease cardiac work. And then after you kind of do that, that's when you get into risk stratification. And there's 2 ways you can do this. You can either do it with the TIMI score, which is easy. You know, you can kind of do this quickly. You can learn it. You can do it in your head if you're a cardiologist, or you can do it with a gray score. And the gray score you actually have to kind of like put in to a calculator to do it, so it's a little bit more cumbersome. So low risk equals TIMI 0 to 2, or GRACE less than 108. So this is basically patients get conservative management. You're really not, they're pretty low risk. So what you can do is a stress test with conservative management. And then you can base your cath off of that stress test, right? So if the stress test is positive, you cath the patient. If it's negative, send home. This patient didn't fall here, right? This patient fell in the intermediate risk. And that intermediate risk is 3 to 4. So for these patients, you're already treating them accordingly with the correct, right medicine, but you need to cath them within 72 hours. And the last one is going to be the high-risk patients. These are patients really anything above 5 for their TIMI score. And or greater than 140 for their gray score. And these patients need a cath in 24 hours. The only thing that I'll say for this is that troponin and EKG changes are independent prognostic factors of the TIMI score. So if really someone has an upgoing troponin or worsening dynamic EKG changes, you're probably going to want to get them a cath in 24 hours. Those are independent prognostic factors. And I think when you really have those, that you kind of may want to not abide by the TIMI score for risk stratification. Then only last thing, so all right, say this patient we have, he comes to the hospital, his chest pains go away, you're the night float. I had this happen a lot of time, right? You're the night float. What type of things would you need to be called for overnight to make this patient go to the cath lab right away? You guys can put that in the chat or answer out loud, whatever you guys want to do. So what would be like emergent indications for NSTEMI or unstable angina? Yeah, perfect. I think that's the biggest one, right? You get a call overnight, the patient has worsened chest pain. First thing you need to do is get an EKG, because what if they just thrombose their entire coronary artery and now they have a STEMI? And that happens. People come in with NSTEMI, they're treated accordingly, and they get a STEMI. And then if they get a STEMI, they got to go to the cath lab within 90 minutes, right? They're going to go to the CCU or they're going to go directly to the cath lab. So if they're NSTEMI or they're unstable angina that turns to a STEMI, boom, you got to go. Always remember to get an EKG on a night float and any of those red 1-2 patients that have obviously like new onset chest pain. What else? So the other things overnight that may make you do it, so electrical or hemodynamic instability. So if the patient's having a bunch of ventricular arrhythmias, they may need to go early. If they're becoming hypotensive, especially if they're not on the nitro drip and they're still hypotensive, you really want to get them the cath as soon as possible. The third one is going to be refractory chest pain. Basically, it's a sign of ongoing ischemia and that they're failing medical management. And then the last one for these patients is going to be like new heart failure. So really any of those things you get overnight, you're probably going to want to call the fellow anyway if you're worried about anything at all. But these are the things that say, okay, we got the patient. Maybe we thought we had 72 hours to cath them, but turns out we got to cath them as soon as possible. We need to get, the correct people on board to start planning that. All right, cool. This is just basically kind of what I taught here. All right, so this is the patient's cath. I'm hoping it works. All right, does anyone know what, let's see, this artery is? I'll keep playing it. Nice, yeah, so that's the LAD. Yeah, exactly. And this is going to be in the RAO axis of looking at this. So that's the LAD. And what does this make, this one coming down here? One. I'll play it one more time. So that would be the LC. So here's the left main right here, going on to LCX and the LAD. The LAD like has some perforators coming through that goes to the septum. That's kind of sometimes how you can tell. It also kind of wraps around the underside of the heart, goes down anteriorly. So there's some of the ways you can tell it's LAD. If you guys want to see, there looks like there's something going on right here. And also, it looks like there's something going on. Where is it? I think it might be easier to see in the next film. I'm not going to go through this because we don't have that much time. But this is just showing, this is just a cool little graph of like what the different views are during cardiac cath and kind of what you see based on those views. So it's pretty sweet. So this is another view. I think the only thing I want to teach is that people will use these views to really see the specific of coronary arteries. Sometimes, like as you can see here, it's a little hard to see the LAD, especially where it first comes off, because I think there looks like there's a couple of like kind of arteries in the way. So what they do so they can see anatomy a little bit better is they'll just take it from a different view. So if you look at this view now, that one artery is kind of out of the way, and you can see the LAD a little bit better. And you know what we're really looking at right here is this lesion right here. So this is a 90% stenosis of the LAD, and then here is a 90% stenosis of the LCX. And I'll play that one more time for you guys, just to take a look at it. It kind of comes out in view, but you can see it pretty well. So this would be the left coronary, like left main artery. Here is the right coronary artery. We were kind of talking in the background. But as you guys can see, this one's kind of interesting, in which it's pretty shoddy, but it fills. You see that there's an occlusion right here. And then this one's kind of cool is that you can see that there is collaterals here. So yeah, I'll try to show it to you right quick. So you can see here, it's kind of blocked down here. The blood goes this way, and it's a right-to-right collateral where their blood starts coming back. So there's 100% occlusion in this right coronary artery, which is why basically that blood's filling this one right here and coming back to try to fill the rest of that right coronary artery. So 100% occlusion. All right, cool. So next question is, this guy has 90% stenosis of his LAD, 90% LCX, 100% RCA. There was some diffuse smaller disease. I'm not a cardiologist, so I wasn't going to say everything, because I'd probably get it wrong. But there was some diffuse smaller disease in there as well in some of the smaller vessels. He gets an echocardiogram. The echocardiogram is normal. His EF is normal. Shows that there's maybe an old scar in like the kind of like the septum or like the inferior area from that old Q wave. But But anyway, so what is this correct management for this patient? Do you want to do a PCI, the drug-eluting stent of all those lesions? You want to say, hey, let's just do aggressive medical management. You want to do a cabbage, or do you want to do a PCI or the bare metal stent? So, get back to Kahoot. What am I doing? All right, quiz time. I'm running out of time. All right. Oh, most people got it right. Nice. I thought that was a hard question. Entresto, still killing it. All right. Oh, crap. How do I pause this? No. Oh, man. My bad, y'all. Maybe I can replay this one. All right. So, the correct answer here is cabbage. So, really, when do we do cabbage versus doing PCI? And there's certain things that you look at that'll say, okay, this patient's not someone that we can really stent, or maybe they won't have the best outcome with a bunch of stenting. So we're gonna have to do a cabbage, right? So here's a cabbage. Here's some saphenous vein grafts here, and then here's that typical Lima to LAD right here. It's kind of cool seeing that the Lima actually like comes off of the subclavian on the left side right there. So what kind of things do you think about? So one of the big ones is greater than 3 vessel disease. And actually even 2 vessel disease in diabetes. So that's one time that you're really going to think about doing cabbage. Is if you have that many occlusions, these patients may, especially if the patient's diabetic, they may have better long-term outcomes with doing cabbage versus doing 3 PCIs. The second one, left main disease. There's some research that maybe not, maybe we can stent this, but the current guidelines are still left main disease should get a cabbage. The third one is EF, less than 35%. And this is basically getting to the point that someone with ischemic cardiomyopathy is going to do better if you revascularize, and they're actually going to do better if you revascularize with a cabbage versus PCI. And these are mostly based on the STITCH trial. It's kind of an older trial that a lot of this research is based on. So it may be different now, but we really don't have a lot of the research to say so. The last one is going to be high complexity. So high coronary lesion complexity. And the way that you will calculate this is doing the syntax score. So things that make, lesions difficult to stent is going to be, is it at a bifurcation? If it's at a bifurcation, that stent can jail off this other coronary artery. So if at a bifurcation, it might be a little bit more difficult. If it's very small, it may be more difficult. If it's a really long lesion, you have to put a bunch of stents there, so that can be difficult as well. Other ones that you think about is if there's any chronic thromboses or like a big total occlusion. Like a 100% occlusion you really can't get through with the PCI, so that's something that you might want to think about doing a cabbage for. So that's another one. And also if they have valve disease that they have to intervene on. So these are the things that you really want to look at, and this is the syntax trial. And this patient was diabetic. The patient was diabetic. They had 3 vessel disease, and they had 100% occlusion. and they also had a lot of diffuse small disease, so they should get cabbage. All right. So I think I by accidentally messed this one up, and I already put the question on Kahoot, but I'll just kind of go over this real quick. So he gets a cabbage with Lima LAD, he gets a saphenous green VAS RCA. What is the correct long-term antiplatelet regimen? So here, ACS in non-stented patients, kind of what do you do for antiplatelets? And I think the first thing I want to tell you, any ACS, if it's stented, if it's non-stented, if they had a cabbage, if they get medical therapy, they're going to need long-term dual medications, right? So what those medications are depends on if you have AFib or you don't have AFib. So our patient didn't have AFib, so he should be on aspirin and ticagrelor. Remember, we talked about that, the Plato trial and the NSTEMI trial, for at least a year. And then it depends, right? So what do you do long term? So if they have a very low bleed risk, you can continue aspirin and ticagrelor times 36 months. And this is the Pegasus TIMI trial. But if that showed that that did decrease ischemic events at a small increase of bleeding events. So long term, if they're not going to bleed, you can consider doing this for a while, even up to 36 months, and some people will even do it longer. The question is, all right, so what do you do if they have AFib in these non-stented patients? So for that, you'll do aspirin plus. So you technically only Plavix has been studied, but some cardiologists will do ticagrelor as well. And then long-term therapy, it's kind of a question mark. So there's a couple studies, specifically the AFIRE and Orbit AF, that says you can just do single DOAC. Oh, sorry. Okay, this is supposed to be DOAC plus Plavix. So it's single DOAC, but really you're going to consider, you can really do that DOAC combined with aspirin or Plavix based on their bleeding risk. If they're at the highest ischemic risk, you would probably do a DOAC plus Plavix. If they're at the higher bleeding risk, you'd probably do DOAC by itself. Somewhere in the middle, you might want to do DOAC and aspirin. It's not really known, but there may be some new studies coming out of whether that confirm whether you can just do single DOAC. All right, last question. Is question number 6. So this is just a random patient that I made up. The last patient was actually a TMAR patient from a couple weeks ago. So this is a patient, history of hypertension, hyperlipidemia, diabetes, and AFib. This is a really hard one. Comes to the hospital after having an NSTEMI, already on a NOAC. He's treated with a PCI to his LAD. What is the correct long-term antiplatelet, anticoagulant management for this patient? So do you want to do triple therapy? Triple therapy means aspirin, Plavix, or aspirin and another antiplatelet plus DOAC for 3 months. Then you do a NOAC plus single agent indefinitely. You want to do a NOAC plus an antiplatelet for 1 year, then do NOAC plus minus single antiplatelet indefinitely. Do you want to do NOAC and aspirin indefinitely? Or do you want to do triple therapy times 3 months, then NOAC and Plavix times 9 months, and then NOAC alone? So I ended it with the hardest question imaginable. Grant shaking his head. I'm sorry, Grant. I had to do it. All right. But this is for all the money, so we had to make it interesting. So we skipped this one. We're all still in the same places. So what do you guys want to do? All right, most people got it right. Perfect. So ACS. So the podium is Justin, number 3, GJ, number 2, and did Entresto fall or is Entresto there? Entresto. Entresto, I'll give you a pack of gum if you come by the chief's office. Who is Entresto? Anyone? You don't need to say it to you if you don't want to. All right. Well, congratulations, Entresto. All right. So I'm going over a little bit, but we do start late. So here kind of is the chart I made because it's very confusing. So what kind of DAP therapy do you want to do after drug-eluting stent? So it kind of depends. The first thing it really depends on is does the patient have AFib or the patient doesn't have AFib? So no AFib. This is the patient. It's kind of similar, right? If they have an NSTEMI, STEMI, you do aspirin and ticagrelor or prasugrel times 12 months, similar to that previous to our patient that we did this thing on. This is, like I said, Plato and Triton trials. And then for long-term, this is Pegasus TIMI. You can do it up to 36 months if they're a low bleed risk. The only thing that I'll say is that ticagrelor, not studied in AFib or stable coronary artery disease, which is why if the patient's stable, this is like someone who got like an outpatient, who had stable angina, maybe got very severe, was impacting their quality of life, they get a stent outpatient. These patients you're going to want to do aspirin and Plavix, and then for long term, you want to check out their DAP score to see if they should be on aspirin and Plavix long term, or they should just be on single agent Plavix. And then, like I said, Plavix was not studied in atrial fibrillation yet. So if the patient needs dual therapy, they're going to get NOAC and Plavix in the short term. Though, because of these trials, ticagrelor is acceptable in an NSTEMI or unstable angina. And then long term, what do you do? Similar trials last time, AFIRE, Orbit AF. Not really sure. Maybe we can do a single agent NOAC, especially if they're high bleed risk. But it really depends on their bleeding ischemic risk, and everything should be individualized. So the last take-home point that I really, and I didn't touch on this, triple therapy in patients with AFib and PCI is no longer recommended, and that is the Augustus trial. No longer routinely recommended. So you don't just get every single person who had AFib and get the PCI. Not every single person is going to be on triple agent therapy for 2 months. That's no longer a thing. There's some people still do practice like that. All right, that was a lot of stuff, but I feel like we got over most of what I was trying to hit today. I won't go over all the take-home points because we're a little over. Does anyone have any questions at all? All right. Thank you.